A significant proportion of patients in hospital beds have excess lengths of stay and could be looked after in an alternative setting. Over the last 30 years, the number of hospital beds has more than halved, while over the last 8 years, there has been a steady growth in all areas of hospital activity. It's estimated that up to 50% of beds are occupied by people who could be cared for in community settings. As such, UK health policy is shifting towards more care being provided out of the acute hospital setting. Many out-of-hospital care plans are already in existence, but may not have sufficient funding or infrastructure in place to support the capacity required to deliver a wider service. And so the government, through its NHS long-term plan, is looking to reduce those barriers by investing £4.5 billion increase in spending by 2023-24. By focusing on the needs of the patient, enabling better links between healthcare professionals and providing care closer to home, hospital trusts can reduce unnecessary workload and achieve a better quality of care for their communities. Evidence suggests that out-of-hospital healthcare, when delivered well, can provide considerable benefits for both patients and healthcare providers. These include a reduction in unnecessary hospital admissions and visits to hospital-based clinics, better management of chronic conditions, a reduction in hospital waiting times, and a reduced risk of treatment and hospital-associated complications. For hospitals, there are potential cost efficiencies in delivering care in alternative settings. Trusts can also focus integrated services on those patient groups most likely to derive the most benefit. For patients, benefits include an improved quality of life. Individualised care plans can be tailored to a patient's specific needs. They're empowered to have more control over their care packages, strengthening prevention, self-care and treatment compliance. Being surrounded by family and friends through their treatment improves mental well-being. Some examples of current out-of-hospital care models include hospital at home, OPAT services, primary care networks, virtual hospitals, community hospital hubs, mobile medical units, and rapid community response teams. Examples of the types of therapy or treatment options suitable for out-of-hospital care include antibiotics, fluids for hydration, chemotherapy, end-of-life drugs, pain management, nutrition, and respiratory conditions. Let's look at a successful out-of-hospital care model example. Heart failure accounts for 2% of the overall NHS budget and 1 million bed days per annum. The average length of stay is 12 days, with an approximate cost of £3,976 per episode. With this in mind, the British Heart Foundation funded a pilot study to implement and evaluate an IV diuretic community programme over a 2-year period. The results of the pilot demonstrated that 79% of interventions resulted in an avoidance of a hospital admission. The average length of intervention was 7 days, with 869 bed days saved. With the average cost of each intervention around £420, this provided net savings of slightly under £200,000 over the pilot period, and with 100% of patients and 93% of carers preferring home-based treatment to hospital admissions, the programme demonstrated key benefits for both hospital trusts and patients. So, what does this look like for the individual? Let's meet David. David is a 59-year-old who underwent a total knee replacement 6 months previously. He presented at his orthopaedic outpatient clinic appointment with increased pain, swelling, warmth, and redness around the joint. He was admitted to hospital with a suspected deep prosthetic joint infection. After confirmation of diagnosis, David went to theatre for the first phase of a 2-stage revision. Post-surgery, he had a PICC line inserted for administration of his IV antibiotics. If the hospital did not operate an OPAT service or had limited capacity, David would have remained in hospital for 6 weeks to receive his required course of IV antibiotics. Instead, post-surgery, he was referred to the Trust OPAT team and assessed as a suitable candidate for self-administration OPAT, SOPAT, with delivery of his IV antibiotics by an infuser at home. The OPAT team educated both David and his wife on self-administering his IV antibiotics. along with care and maintenance of the PICC line and infuser. David was then discharged home after 5 days. An OPAT nurse visited David the day following his discharge, then on scheduled visits over the following weeks. During this period, David also attended fortnightly reviews with his orthopaedic consultant at the hospital outpatient clinic. David's feedback on SOPAT was that whilst initially he and his wife were a bit nervous about managing it, they soon became confident and felt supported by the OPAT team. He felt more comfortable receiving his treatment at home, and he benefited from not having to wait in for the OPAT nurse. This was particularly important when he was more mobile in the latter weeks. He could plan his day more easily and have more control over his time. He was able to continue working from home, and friends and family were able to visit more easily, making the whole treatment process more comfortable and manageable. Delivering out-of-hospital services requires integrated care models, where a variety of providers work in partnership to deliver a seamless service with benefits to both the patient and the health service. With the government committed to investing in out-of-hospital care models, now is the time to drive those conversations to develop or expand integrated care services where capacity is limited. Contact us to see how Vigon can partner with you in the acute to community journey.